Hey guys, welcome back to the Medicinal Chemistry course presented by the Paracetamol Academy. Part 2 of the drugs affecting cholinergic neurotransmission will be presented by me, Carl Bushara. So, parasympathetic antagonists are cholinergic drugs that inhibit the effects of the parasympathetic nervous system. They can also be called cholinergic antagonists, and there are two types, depending on which receptor that these agents are going to be affecting. The muscarinic antagonists are divided into non-selective muscarinic antagonists and selective M1 antagonists, whereas the nicotinic antagonists are divided into ganglionic blocking agents and neuromuscular junction blockers. Firstly, we're going to start with the muscarinic antagonists. They are compounds with high affinity to the muscarinic acetylcholine receptors and have no intrinsic activity by themselves. They act competitively, meaning that their effect can be overcome through the administration of muscarinic agonists or acetylcholine. They have various effects, including an antispasmodic effect, meaning that they can be used to relieve the smooth muscle spasms. There should be an important distinction here between smooth muscles and the skeletal muscles. Here they're working on the smooth muscle relaxation. They can also lead to mydriasis, so the dilation of the pupil, and they also have an anti-secretory effect, which means that they can decrease the gastric or salivary secretions, etc. There are two types of muscarinic agonists, those that are quaternary amines, meaning that they are ionized and they have, as a result, low GI absorption, and tertiary amines, meaning that they're non-ionized and can be absorbed systemically. So these are two naturally occurring compounds which were discovered very early on, and that enhanced our understanding of the parasympathetic stimulation. They are atropine and scopolamine and are both sourced from Atropa belladonna, also called deadly nightshade. Now, let's move on to the SAR of muscarinic antagonists. There are 5 things to note for these compounds. First is that the R1 and R2 substituents should be carbocyclic or heterocyclic. These rings can be identical, but the potent compounds usually have different rings. Usually, one ring is aromatic while the other is saturated. Next, the R3 substituent can be a hydrogen atom or a methoxy group, but more potent compounds have a hydroxyl group or a hydroxymethyl group. Then, the amine group can be either tertiary or quaternary, with quaternary groups being more potent. And finally, the distance between the ring substituted carbon and the amine group can range from 2 to 4 carbons, with 2 providing the most potent compound. So let's begin with the non-selective muscarinic antagonists. Regarding the anticholinergic amino esters, here we have the compounds glycopyrrolate and propanthyline. These compounds both have quaternary amine groups, making them ionized. As a result, their GI absorption is poor, making these drugs not very suitable if systemic effects are desired. So these drugs are mainly used for their local GI effect. Continuing with the anticholinergic amino esters, both cladinium bromate and ipratropium contain a quaternary ammonium group, making them ionized and thus they follow the same ideas that I previously stated. Concerning flavoxate hydrochloride, the ionization of this compound is pH dependent, meaning it can either exist in an ionized or non-ionized state depending on the pH of its environment. Oxyphencyclamine, however, contains a tertiary amine group, making it non-ionized, and thus efficient when systemic absorbance is desired. Moving on to the anticholinergic amino alcohols, named for the hydroxyl group on the ring substituted carbon. Both procyclidine and trihexyphenidyl contain a tertiary amine group, meaning that both of them exist in a non-ionized state and thus are efficient for systemic distribution. Now for the anticholinergic amino ethers, named so because of the ether group adjacent to the ring substituted carbon. Both orphanedrine and benztropine contain tertiary amine groups and are thus non-ionized and so have a systemic effect, and both also possess some antihistaminic activity. Moving on to the muscarinic antagonists that are selective to M1 receptors. These drugs include tilenzepine and pidenzepine, both of which are in the chemical class of diazepines. Because they have a different chemical class than the previous agents that we talked about, the patients that are administered these drugs experience less CNS depression. In addition, the main indication for their use is ulcer treatment. There are two types of nicotinic receptor antagonists, the ganglionic blocking agents and the neuromuscular junction, or NMJ, blockers, further divided into depolarizing agents and non-depolarizing agents. These agents are also competitive antagonists, meaning that their effects can be reversed through the addition of acetylcholine. Ganglionic blocking agents function by blocking the autonomic ganglia highlighted in the figure. This binding would inhibit ganglionic transmission, thus blocking the stimulation of the efferent sympathetic and parasympathetic transmission. For example, since using ganglionic blockers would block the autonomic ganglia in the adrenal medulla, this would prevent the release of epinephrine and norepinephrine, which would in turn lead to decreased stimulation of the alpha receptors in the vascular smooth muscle cells. Thus, this would lead to vasodilation. Examples of ganglionic blocking agents include the bisquaternary ammonium class, which includes both hexamethonium and pentolinium, as well as the sulfonium class, which includes trimethophan. All of these compounds are ionized, meaning that they have poor GI absorption and thus poor systemic distribution. However, ganglionic blocking agents with secondary and tertiary amine groups, such as mecamylamine and pempidine respectively, they are non-ionized and thus can be given orally with good GI absorbance to lead to systemic effects. Neuromuscular junction blockers work by blocking the postsynaptic acetylcholine nicotinic receptors on the muscle cells. This blocks the neurotransmission across the neuromuscular junction and leads to the paralysis of the affected muscle cells. Thus, the main indication of this drug is used for skeletal muscle relaxation, and it's usually used in adjunction to anesthesia because it decreases the concentration of anesthesia required to put the patient under. Side effects include bronchospasm, hypotension, and cardiac disturbances. The mechanism of action of non-depolarizing agents is a simple one-step blockade process, whereby these agents act as a competitive nicotinic receptor antagonist. All these agents are ionized, meaning that they have no CNS effects, with the exception of etracurium. Two classes include benzoylisoquinolines and ammonium steroids. The first agent we're going to be discussing is a prototype of the non-depolarizing class, and it is a benzoylisoquinoline derivative. It has a very long duration of action, and it is called tubocurarine. Continuing with the benzoylisoquinolines, we have mivacurium chloride, which is of note because of its very short duration of action, and we also have doxocurium chloride. Atracurium benzoylate is another benzoylisoquinoline derivative, and it is the only agent with CNS effects. It undergoes metabolism by Hofmann elimination and hydrolysis, as can be seen by the adjacent figure, and the end product of both reactions is inactive. Finishing up the non-depolarizing agents, we have the ammonium steroids. The figure that you see below is the base figure, and it has various substitutions to produce different kinds of compounds. Of particular note is pancuronium bromide because it has a very long duration of action. Now, for all the non-depolarizing agents, the effects are reversed by using acetylcholine esterase inhibitors, because these agents would increase the concentration of acetylcholine, which would compete with the non-depolarizing NMJ blockers, and thus prevent the antagonistic effects. The mechanism of action of depolarizing agents is more complicated. It's a two-phase blockade, whereby the first phase is a stimulation phase, where the agents act as an agonist that would bind to the receptor and cause stimulation. However, because this agent does not detach from the receptor, it causes continuous and excessive stimulation, leading to receptor desensitization, or the depression phase. An example of one of these agents is succinyl chloride, which is a dimer of acetylcholine, if you noticed, and it's rapidly hydrolyzed in an aqueous medium, so it has a very short duration of action. To reverse the effects, we have to use non-depolarizing NMJ blockers, because they bind to the nicotinic receptors, displacing the depolarizing NMJ blockers, and preventing the receptor desensitization. If you guys would like more information, please feel free to check out the reference of this textbook. So thank you guys for tuning in. I hope you enjoyed and understood the points I made in the chapter. Don't hesitate to ask any questions you might have in the comments below, and we will make sure to get back to you. And stay tuned for chapter 6.